over to the rest of the team. Hold on one second. I will. Okay. So I'm going to begin with a quick presentation on the new state framework so that people have that context before we move into the rest of the report on COVID-19. As everyone I'm sure knows by now, the governor and California Department of Public Health last week announced that the state has replaced the state monitoring list and variance process effective August 31st, so effective yesterday. The new framework that the state put out is based on a 4-tier system with different colors for each tier. Tier 1, which is purple, has the most significant restrictions under the state order, and it generally is in alignment with the prior set of restrictions that were in place for counties that were on the state monitoring list. The other tiers are Tier 2, which is red, Tier 3, orange, and Tier 4, yellow. Each tier does have some level of restrictions, and the governor announced last week that there's no green tier yet because there is no vaccine yet. There's no level that is fully safe, and so they didn't want to indicate otherwise in their system. The new system, there were a lot of the old county monitoring list system had a number of different metrics, including hospitalizations and percentage changes and so forth. The new system is more simplified. It's based on 2 factors. One is the daily case rate per 100,000 residents. It's a 7-day average with a 7-day lag. And the second is the positivity rate in a specific county. Based on those 2 factors, which are independently assessed, you are placed into the tier based on how you're doing on the worst of those factors. So in other words, if on one of those factors, a county would qualify in the orange tier, and on the second factor, a county would qualify in the red tier, the county as a whole would be placed in the red tier. This is another slide pulled from the CDPH site, and what I wanted to note here, it just displays the same information in a different format. But what I wanted to call attention to, and this is something really important for our county, is that the case rate number is adjusted by the amount of testing that you do. So in other words, counties like Santa Clara County that are doing more testing than the state average receive credit and actually have the case rate in the county adjusted downwards to reflect the increased testing. And so that's also true for counties like San Francisco that have a lot of testing. And that's being reflected. That was, for example, why San Francisco ended up in the initial placement in the red tier, and why Santa Clara County, although we did end up in the purple tier, is getting a significant adjustment for the increased testing. So the more testing we do, the bigger the adjustment is to the case rates. I also want to note the state has said that they're also going to implement a metric related to equity, ensuring that testing is happening in high-risk populations. That's, of course, been a focus of our response here in Santa Clara County with our public health department. We don't know what exactly that metric looks like yet, but we're pretty confident that we are, because we've been focused on that for so long, that's probably something that we'll be able to show good progress on relative to other jurisdictions. The way that the tiers work, a county has to remain in a tier for at least 3 weeks before you can progress to a less restrictive tier. And you have to meet the metrics for that tier for 2 consecutive weeks. The state said they're going to calculate these each Tuesday. And for the very first set of placements only, counties can actually move to a lesser restrictive tier on September 8th if they had met the metrics in the prior 2 weeks that would allow for them to be in that lower tier. So for Santa Clara County, this is the map of kind of where the state was placed with the initial release. For Santa Clara County, we were, as I noted, placed in Tier 1 purple like most of the state based on the data for the weeks ending August 11 and August 18. But our data for August 25th did meet the criteria for the red tier. And so if we do meet that, those criteria for the week that's ending today, we would then be able to move into the red tier on September 8th. So we don't know that as of yet, but we should know that soon. And again, this is because in significant part of the credit that we get against the case rate due to the volume of testing in our county. So what does this mean? Well, the state has created a different framework of what can be open under the state health order based on the tier that you're in. So for purple tier, the difference from what things looked like the week before is that hair salons and barbershops are now open statewide for indoor operations. Previously, they were only able to be open for outdoor operations in counties that were on the monitoring list. And shopping malls were previously closed and can now open at 25% capacity. So those first two items that have gone into effect here in Santa Clara County, we have already adjusted the local directives to reflect that. We've already adjusted the website locally to reflect that. And those were, of course, activities that were already allowed under the county's local risk reduction order that went into effect at the beginning of July. And so now that the state allows those activities as well, they're allowed by the state, they're allowed locally, they can continue. There are many other things that can open under the state order if you end up in the red tier. The far and away most significant of which is that K-12 schools can open 14 days after you have been in the red tier. And so that's consistent with the state basically saying previously that if you were off of the monitoring list for 14 days, schools could open. And since they've pegged the monitoring list generally, the criteria to the purple tier, they're saying if you come off that purple tier for 14 days, then schools can open. You'll see the other list of items. I'm not going to read them all off, except to note that many of these are items that were previously opened locally under the county risk reduction order. And so now if the state lifts those restrictions, those will be able to resume in Santa Clara County. However, there are certain other ones that are prohibited under the risk reduction order, and those would remain prohibited locally by the local order. In addition, the state continues to have directives and guidance that are sector specific for how operations are to be conducted safely. In addition, and the governor again emphasized this, and Mark Galley emphasized this last week, the local orders like our county's risk reduction order and associated local directives remain in effect. That includes our density requirements, strict face covering requirements, social distancing protocol requirements. We are, however, looking at directives to align them with new state guidance so that there's as little friction as possible. And just a reminder overall, and I know the board knows this very well, but always a reminder for the public, the stricter of the two orders does control. And so that means, for example, the state, if it has a capacity limit, like if we're in the red tier, 10% for gyms, that is probably a lower limit than the county's local risk reduction order. And so that lower limit would be the applicable limit. And of course, the opposite would be true as well if the county risk reduction order had a stricter requirement. That concludes my kind of brief overview of the new state framework. I did also want to mention one other important state update that's not directly related to kind of the COVID framework, and that is that yesterday state legislation AB 3088 was approved and has gone into effect, which relates to a statewide program and policy for dealing with evictions and foreclosures. There is language in that in that bill that includes preemption of local actions. We are analyzing that bill. It's going to take us a couple days to do the analysis because it's not a straightforward preemption provision. And we will, of course, get that information both to the board, but also to the public, because it will have an effect on the rules here locally. And we know that the local eviction moratorium website and all of that will need to be updated to reflect that. So more to come on that, and we will work on that as quickly as we can. But it does appear that it will have a significant impact on our local eviction moratorium. And like I said, that was a state law that took effect immediately. So that concludes my piece of the presentation, and now we're going to go to Dr. Cody.
Dr. Cody, you may be on mute. There you go. Dr. Cody?
Having technical difficulties. We'll be right there.
Okay.
Good afternoon, President Chavez and members of the board. I had some technical difficulties, so I am sitting at Dr. Smith's station. Can you hear me all right?
We can. Thank you.
Wonderful. So I'm going to give you an update on 3 different items before passing the presentation along to colleagues. First, just an overview of the epidemiology of where we are in the epidemic. And then I wanted to give you an update on what we're seeing at work sites, transmission in work sites, and finally a brief update on schools and the school waiver process. Here you see the epidemic curve that you've seen many times, and I just wanted to point out a few things. Again, the bars at the bottom in yellow are cases among long-term care facility residents, and in orange among staff. And what you continue to see is that, yes, we do continue to have cases, but as a proportion of the total cases, quite a bit less than we were seeing in late March and early April. You can also see that our case numbers peaked in the middle of July, and they're just maybe beginning to gradually come down. Next slide. As far as who is infected and who do we see really driving this surge in cases, the increase in cases, what we continue to see is a pattern that members of our Latinx community are overrepresented given their proportion of the county population. It's remained about stable. So in the last 3 weeks, 59% of our reported cases were among Latinx residents, and they represent just 27% of our population. In addition, we continue to see that young adults, we see the highest rates of infection among young adults. And just to walk you through this rainbow spaghetti of a slide, there on the y-axis, those are the rates per 100,000 and over time. And you can see that the rates in all the age groups really picked up in July. In all age groups, maybe they're starting to come down a little bit, but those top 3 in green, yellow, and blue those are the case rates among young adults. They're broken out differently, but essentially that's the 18 to 34-year-olds, and they continue to have higher rates of infection than other age groups. Next slide. This shows our trends in hospitalizations. And remember, this is the total number of people hospitalized for COVID across all the hospitals in the county. And this is a sort of a daily count across all the hospitals. And what you can see is that in late July, it's quite high, about where it was in April when we were really in greatest trouble. And since then, very gradually now, we're confident that it's drifting down. So a little bit bumpy, but beginning to see a little glimmer of drifting down over these last few weeks. Next slide. So here I just wanted to share with you a little bit of information about what we're observing in our worksite investigations. And I want to caveat this in a few ways. One is that these are the number of work sites where we've observed 3 or more cases in a 14-day period, and it's by work site type. But these are just the overall numbers of work sites where we've documented 3 or more cases from late May through most of August. But we don't really have a comparator. In other words, I can't tell you of the number of construction work sites that were in operation, how many of them had a cluster of cases. And I think that's really important. So I just want to put these numbers into context. And I also want everyone to remember that construction was one of the first industries one of the first sectors to reopen after the shelter in place, and also one of the first sectors to begin reporting illnesses among workers. But with all that said, what you can see is that there's a variety of different work sites that have reported 3 or more workers with illnesses in a 14-day period, ranging from construction to grocery stores, to office settings, to hotels, to places of worship. And in the next 2 slides, I just want to share a few more observations about what we're seeing at work sites. So they sort of fall into 2 different buckets. One is where it seems that the workers acquired their infection at work. And so among this group where the interview really indicated that the infection was mostly acquired at work, we see a couple different themes. One is that in public-facing jobs where it's difficult to get a physical distance between the worker and a customer or a member of the public, for example, a cashier, we see infections there. And the other is seeing infections among workers who have a lot of interactions with their coworkers. So for example, in a small restaurant kitchen with a number of kitchen workers together, they may not be able to keep physical distance, or because of the temperature in the kitchen, they may not be keeping their face coverings in place for an entire kitchen shift, and we've seen transmission there. In addition, at work sites where there's a whole bunch of different worker types that may need to come together, for example, a construction site with a lot of different subcontractors that are needing to collaborate on a particular project. We've seen transmission there. And then finally, at a number of different work site types, we've seen transmission at places where the workers may be taking a break and not wearing a mask or keeping their distance from each other, for example, during a lunch or break room. The second example is where we see infections among workers, but we actually don't think the infection was acquired at the work site. We think the infection was actually most likely acquired somewhere else, and that might be in a number of different ways. One is in the household, but they're diagnosed at work and are sort of associated with the work. And sometimes this may even look like a worksite cluster. For example, if there's a number of folks from the same household who are at the same worksite, we see this not uncommonly at construction sites. or they may have been contact with someone else in the home, for example, a relative taking care of a child. That relative infects the child infects the parent, and then the parents show up at work and are documented there. Sometimes it happens with coworkers gathering outside of their work setting, if they need to get to work together, or if they join each other after work. And sometimes it happens if coworkers have a second job site in addition to the job where the infection is reported or documented. So now I want to turn and talk a little bit about our school waiver process. This is an answer to some of the questions that came up at the last board meeting, and just sort of go over in general how this works. So the waiver applications are submitted by a school district or an individual school, and then we review them. And there's really a multidisciplinary team that are looking at the applications. Our school team, which includes representatives from schools, as well as county council, as well as public health. And a couple of things happen. One, we're just looking at the application to make sure that all the parts are complete. We have all the information we need. And then sometimes there's quite a bit of back and forth and technical assistance and questions to ensure that the school is ready and able to implement safety protocols. We also, of course, want to confirm that the school has consulted with their key stakeholders. And then finally, after all that process is done, we just consult with California Department of Public Health to confirm that they agree that the waiver should be granted. Then we notify the district about the result, and if the waiver is granted, we post it to our website. So this gives you a sense of the status of applications from 3 different types of schools or organizations: our public school districts, charter schools, as well as private schools. And just to walk you through there, in the first column is the number of waiver applications submitted. The second column is the number of schools represented. For example, a district may have 1 or several schools in the district. The third column is the number of applications for which an initial interview has been conducted and the process has gotten started. And you can see the process has started for all the waiver applications submitted. And then the final column is the waivers granted. And actually, this is a very dynamic column that's changed since we finalized the slides yesterday. So for example, as of today, there's a charter school that's waiting approval from CDPH, but is final as far as we're concerned here in the county. We have a number of different touch points with schools and have for many, many months. We have a dedicated schools unit in our emergency operations center, and that's to help facilitate communication between schools and the many different disciplines here in the emergency operations center. They have both a dedicated call line as well as emails. A number of other touch points, regular touch points, a weekly call with the school district superintendents, a different call with a different set of folks, weekly with school nurses, another set of weekly calls with school district HR administrators, and finally another weekly call with school chief business officers. So again, a number of different touch points between disciplines in the county EOC and various disciplines at schools. And finally, we have a schools reopening task force that's co-led by the Public Health Department, the County Office of Education, and the Office of County Council. And the task force has held a series of webinars over the last couple of months. And this is really to ensure that the information that we have is sort of what we know at the time is shared with stakeholders. And then there's an opportunity for some back and forth. And last but not least, we had a town hall that we participated in with Supervisor Ellenberg and President Chavez. So that concludes my update, and I think next up is Dr. Fensterscheib.
Your audio. Go ahead and do that. Good.
Good afternoon. Can you hear me?
Yes, but very lightly.
Okay. How about now?
Better, but you're echoing. Sorry.
Trying a third time. Is this that? Nope.
That was good.
Sounds like we're good now. No, we're not.
Yes.
But I'm told to go ahead anyway. Okay. So let's bring up my, okay, there's the first, I think that's the second slide for me. Go back one. Oh, okay. We're going to get up to my slides in 1 second. Bear with us. Okay, here we are. So this is an update on our testing. Again, we presented information last week, and so as far as numbers goes, there's not large changes this week, but I have some additional information to provide. So this first slide is an updated slide with our daily numbers. So each one of those lines is a single day through August 28th, and you can see there's a red line, squiggly line on there, which is our positivity rate, and you can see what the positivity rate is on any single day. And the next slide is the 7-day average test count, and you can see our recovery from last month, and we've been testing 6,000 to 7,000 people per day. The red line again, our positivity rate, which is just under 4%. And so it has been dropping a bit. And this is for all the tests that have been done throughout the county. Let's go to the next slide. All right, so this slide is showing the total number of countywide tests during a 3-week period. And that 3-week period is August 1st to August 21st. And there were over 132,000 tests done countywide during this period. And as we've noted previously, the positivity rates, which you can see on the far right, are higher in East San Jose at just over 7.6%, and then again in South County at over 7%. Let's go on to the next slide. Okay. The county health system during the same period tested over 43,000 individuals, and this represents 33% of all the testing that's done in the county. That's the top. The bottom slide, the bottom part of the slide is a table which is showing testing done by our pop-up sites, again, during the 3-week period that I mentioned. Nearly 70% of the county health system testing was actually done by the pop-ups. And that represents also about 22% of all testing done in the entire county at our pop-up sites, with a concentration, as you can see, percent under that second column on the bottom, percent of tests during the 3-week period. 49% of our testing, as far as where we go, is in East San Jose, and 22% in South County. Let's go on to the next slide. This slide is our dashboard that you have seen before for various healthcare systems during a 1-week period. So this is a period from August 15th to the 21st. Again, the first column is the total number of tests done by the facility. The next is the daily average, and the third column shows the number of tests done per 100,000 patients served by that particular facility. And let's go to the next slide. This graph is looking at the trends again over time for each of our healthcare facilities, and this is from June 8th through August 28th. Again, these are based on rates. The green line is the county as a whole, not just the health system, our health system, but the county as a whole. doing over 300 tests per 100,000. The county health system continues to do the majority of tests. The rest of the healthcare facilities have shown little change over the last week since I last showed you this slide, so they are fairly stable. Let's go to the next slide. I wanted to give you some data specifically to our large drive-through site at the Fairgrounds. This site was launched, as you know, on August 18th, and the capacity has increased from where we initially started at 500 tests per day up to 1,000 tests per day, and it operates 6 days a week. Today we reached our maximum of 1,000 tests. We had 1,000 appointments earlier today that are being seen today. The turnaround time to result is still around 2 to 3 days, so that's very good. And then this first slide, this map, gives you some data specifically which shows where people live who are coming to the Fairgrounds to be tested. And we can see that people are going to the Fairgrounds from most areas of the county, with a heavier concentration from people in the east side and some parts of central San Jose. And then on the right, the map is showing the positivity by zip code of residents of those testing at the Fairgrounds during that period that I mentioned. East San Jose and portions of South San Jose have the highest positivity, and there are a couple small pockets in Sunnyvale and in Mountain View. But when we look at those on our census tracts, that those are very small areas in that northern county area. And let's go to the next slide. This slide shows the number of people going to the Fairgrounds at any given day with the corresponding positivity rates. And you can see that our capacity, as I mentioned today, was good, but we still have considerable capacity on most days. Usually Tuesday is our busiest day. We have our appointments now available online in Spanish. So I would encourage people to take advantage of our testing site at the Fairgrounds at this point. And let's go to the next slide. This slide I know is a bit busy, but it's more detailed analysis of those going to the Fairgrounds. In the 9 days, and that's what's represented here, that we've been open over 5,600 tests have been done. That averages out to about 620 tests a day. And the average positivity rate has been about 4.5%. However, we're seeing increased positivity in those under 24 years of age, and Latinos whose positivity rate has been over 9.6% at the Fairgrounds. And also on this chart, you'll see that 95% of people tested at the Fairgrounds are from Santa Clara County, so they are residents here. 5% live outside the county, but we don't really know whether those 5% represent people who perhaps work here or come here for other reasons. But it's still a very small portion. And then you can see on the right side that this is the cities represented by who is coming to the Fairgrounds. People are being tested from all cities, but as you can see, a majority or 65% of the people going to the Fairgrounds are from San Jose. And however, we'll continue to have our rotating city testing mobile site continue to service the cities on a rotating basis. And then finally is the schedule of our pop-up sites over the next 2 weeks, and you can look at that without me going through it. Again, I wanted to encourage those that want a COVID-19 test to take advantage of any of the public testing sites, and also once again to call upon everyone to make sure that get a flu shot. All providers are currently planning to make them readily available to everyone 6 months and older, and this will truly help us differentiate between COVID and flu, and also help to maintain adequate hospital capacity. So I'll stop there. Turn it over to Dr. Rudman.
Thank you. This is Dr. Sarah Rudman presenting on our case investigation and contact tracing efforts. So our usual metrics that we share with you are displayed here, looking back at the past month. We have roughly the same number of cases, a very slight decrease, fortunately, that we've been responding to in addition to all of their contacts. Continue to be able to immediately attempt to reach all, and our success rate in doing so has increased slightly since our last report, now to 81% for cases and 76% for contacts. And we continue to see about 4% of those requesting any kind of resource. Specifically mapped out here are food, housing, and household items. Next slide, please. So 3 operational updates we'll go into a bit more detail about today, based on the request of President Chavez and Supervisor Ellenberg at our last meeting, specifically regarding our clinical monitoring and resource referral system, our partnerships that are in development with community-based organizations, and further assessment and adjustment for client language capacity and needs. Next slide, please. So President Chavez asked specifically to understand about the warm handoff that happens on the contact tracing side of our relationship with the Housing and Human Services Unit that picks up the ball on the other end and gets people to some of the wide range of county resources available for anyone who needs to isolate or quarantine. So what you see here is a map of several ways in which we attempt to get resources to people as quickly as possible based on the urgency of the need. The individual contact tracer, when they're on the phone with a case or contact, if at any point recognizes an emergent need, that person does not have housing today, or it's at risk of disappearing tomorrow, the next day, or it is urgently unsafe for them to remain in their house, or they do not have more than several days' food available to them, an immediate handoff will happen to the COVID support team to provide those resources. And you see that down at the bottom, that either that caller will be conferenced into the COVID support team, or if it's safe to do so, the contact tracer may hang up on the client, call the COVID support team to have additional conversations, and then link them back directly. If it is not an emergency, our contact tracer will place an electronic referral to a triage nurse who is part of the contact tracing team and has several roles to make sure that every single referral is followed up in an appropriate and timely manner. And we find that those triage nurses are usually able to respond within an hour, sometimes even faster. They are often able to respond to some needs on their own. For example, if somebody says, I have the financial means to buy food, but I'm not sure how to get it. I don't know how to place an order for food delivery, for example. That triage nurse may be able to get somebody to a resource that doesn't need financial supports or doesn't otherwise need to map through the COVID support team. So sometimes they will provide the support themselves. Other times they will still map back via, again, an electronic referral to the COVID support team. And here, again, even with these non-emergent referrals, we tend to get response within 24 hours and sometimes much faster for those non-urgent housing, food, and support services that come from outside the contact tracing team within the COVID support team. If we go to the next page, there's one more element that triage nurse may decide, is that a referral is not specifically for a resource or a human need, but for clinical input. Whether that's because somebody has requested it, they have a complex clinical question. What does my diabetes mean in the context of my COVID? What does my change in my cough mean for how long I need to isolate? Or they may fall into a category where we're particularly concerned about their worsening or the risk that they may worsen clinically. And so for those folks, we ask permission to still reach out to them proactively and have a clinician, usually a nurse or other clinician, reach out to them and just check in several times over the course of their isolation or quarantine. We do this especially for folks who are over 65, who have any medical comorbidity that may worsen their risk of severe complication from their COVID, or who's pregnant. And so we have about 10 clinical staff per day, receiving about 35 referrals a day, the vast majority of which we're able to respond to very quickly. Although some of them, we find that the clients are not interested in their referral when we reach back, or some of them are still in process, and we continue to provide ongoing clinical monitoring for those folks. We found that as this system went live months ago, that the utilization of it, as the contact tracers grew comfortable with it, and as the cases and clients came to know about it, has about doubled in the second half of that period. And again, we're seeing 24, and I apologize, I should say 24 to 48 hours response time for non-urgent referrals. Next slide, please. We're also excited to respond to a lot of the excellent feedback we received from the community in general, from our partners and collaborators based in communities, and from the board as well, that in order to do this job really well in the areas that have been hardest hit by COVID, we really need to connect deeply with those communities themselves and lean on the communities to tell us how to do this job well. And some of that needs to come from close partnership with community-based organizations that have deep ties in communities that are being hard hit by COVID. So we are about to hire 50 full-time paid and benefited positions that are required to have either bilingual ability in the languages that we need most for contact tracing or deep knowledge of African and African ancestry communities, with the goal to embed these positions in community organizations and in ways that link them to all of the resource, the deep knowledge, the connections that those organizations already have, and find ways to make sure that they're benefiting the organizations themselves, as well as drawing on that knowledge to benefit the communities they serve. We'll also be working closely with Promotores to provide education, messaging, and handoffs to these trusted contact tracers as the new cases and contacts are being identified. And so these new contact tracers, unlike our previous workforce, which is entirely remote, may also work on site at a partner organization or in the field. However, we hear from the community is going to be most effective and serve people best. And then next slide, please. I do also want to address, as we think about serving these communities, we were asked, I believe again by Supervisor Chavez, to look at how we were doing on those metrics in some of these areas that are being higher hit, appreciating that East San Jose and South County have had much higher case rates than the rest of Santa Clara County. We did find, and we're pleased to find, that we have equal success rates in reaching people in East San Jose as we do in the rest of Santa Clara County, and slightly higher success rates in South County. We do see slightly higher requests for resources and when we reach East San Jose cases and contacts than we do in other areas. And interestingly, very slightly lower requests in South County, but not major differences. What this tells me is that we're doing something right in terms of reaching out and connecting with folks, but knowing that these areas are being more impacted by the disease, I think it's also a sign that we can be doing better, that doing equal work is not necessarily doing equitable work, and making sure that we would want to be achieving, if possible, even higher rates in the areas that are being impacted even more is certainly a goal of ours. And then final update is just to mention that we have been keeping a close eye on the preferred languages of the cases and contacts who come to us. A particular difficulty is that we often don't have this information at the time we reach out to someone. And so linking somebody to a case investigator or contact tracer who speaks their language is still a challenge we're working on. We do find that about 30% of our cases and contacts speak Spanish and about 1% speak Vietnamese. And if we go to the next slide, this is somewhat well matched by finding that about 14% of our contact tracers and case investigators speak Spanish and about 2% speak Vietnamese. So not exact matches or even increased numbers of those folks speaking the languages that we need to have access to in order to serve the community, but a somewhat proportionate and somewhat representative group. That's part of why we're so excited to have this new cohort of folks coming on board, requiring either that bilingual capacity or that deep community knowledge, as well as making sure that we have opportunities right now for every county worker who's been asked to join us as a case investigator or contact tracer, make sure they have the opportunity, if they're not previously certified bilingual in Spanish or Vietnamese, to do so, to receive bilingual additional pay, so that we show the huge amount of respect and esteem for that skill set and how important it is in the context of everything going on, by making sure that those opportunities are available. So I'll stop there, and I'm passing over to Dr. Kamal.
Alrighty, thank you very much for allowing me to present on the state of healthcare preparedness. Overall, our preparedness is good. Since August 25th, our hospital census has decreased slightly. We've had no further requests for transfers into our county for COVID patients. Our remdesivir supply has increased. Our glove supply has improved. But finally, there is one issue with N95 reuse that may impact our PPE supply and demand I will discuss. So this graph shows our remdesivir supply and demand. As we can see, in the last cycle, we received much more than we did in the past. The orange bars show that there are currently 3,200 vials of remdesivir, which, given our current usage rate, equates to about 2 months of usage. In addition, this week we are slated to receive another 1,800 vials, to the point where now most hospitals feel very comfortable in the amount of remdesivir we have and are turning down some of the allocation we're being offered by the government. This actually reflects both an increase in the amount of remdesivir and also the fact that the overall census nationwide in hospitals has gone down. Our hospital capacity also remains good. Our census is now down to 65% of capacity, whereas in the past we were seeing about 150 COVID positive patients in hospital beds every day. Now that number is closer to 130. Our PPE state is also very good. For the first time, hospitals, SNFs, and the county warehouse have all the PPE that they feel they need currently and also in the event of a surge. However, there was a recent guidance that came from OSHA that recommended reuse of N95 masks. As we recall, back in June, the CDPH had recommended utilizing reprocessing systems with hydrogen peroxide to extend the use of N95 masks. That is no longer recommended, and as a result, our usage may increase. Having said that, we are currently not in dire need. We have over 3 million masks in the EOC warehouse and have an additional 1 million masks on order. In the last 14 days, we have received 23,000 requests from SNFs and none from hospitals. And we have spoken to each hospital who have reassured us that they are very confident that they will have adequate supplies and are also transitioning to the use of elastomeric masks in place of N95s, which can be reused multiple times. Finally, our staffing is also good. The 2 hospitals which have reported shortages are the same ones as before and have reassured us that they are able to take care of this through their own contract, and there have been no requests coming from skilled nursing facilities. As we said last time, we're continuing to collaborate with healthcare facilities on different aspects of surge. And we'll also monitor our PPE usage, our remdesivir usage going forward. Thank you.
Thank you, Dr. Kamal. Michael Ballier here, Director for the Department of Environmental Health, giving an update on the Community and Business Engagement Branch. I think the priority update for us over this last week, in addition to what we presented at the board last Tuesday, is that we've formally launched our new what we call concern or complaint management portal at scccovidconcerns.org. That was a joint effort between the County Council's Office, Public Health, the EOC, and of course the District Attorney's Office. And so just want to again acknowledge all of the great partnerships we've had in working this through. And you will now see that any complaint entry point, whether it was from the DA, Environmental Health, OLSE, or others, will now direct to this particular site. And again, the goal really being a more simplified process for both the public as well as the management on the back end. And I will point out that it is a online database, so it gives us a lot of tools on the back end to run reports and be able to track things such as trends in a particular industry or at a particular type of a particular business that we might be seeing. And then I think the second big item is that we were able to get our countywide enforcement work group scheduled with all of the local jurisdictions, and that meeting is scheduled for September 11th. We look forward to talking with all of our partners at the city to better understand what they've been doing and what some of the needs might be at the local level. And then the third thing is I'll pass over to Betty Young, is an update on the direct education and outreach to a lot of the businesses in the community. And here's Betty.
Hello. As of, next slide, please. Thank you, Dr. Smith. As of Friday, August 28th, we have 21 community health workers in various stages of onboarding who will be deployed on September 8th to lead our, sorry, I'll backtrack that. We have 21 community health workers in various stages of onboarding. We have 53 community workers either deployed in the field or ready for deployment. The community health engagement team responsible for residential engagement will deploy 36 canvassers the week of September 8th. We're all very excited about that. And Dr. Annalili Garcia will be sharing more about that in just a moment. And In our second week of activation, the business engagement team was deployed for 35 hours of canvassing, with 23 canvassers that amounted to 805 total hours of canvassing. Next slide, please. Thank you. The team engaged 774 employers and an additional 344 workers. Employer and worker engagements this week largely focused on concerns of non-compliant customers, having challenges with customers not wanting to wear face covering, not practicing proper social distancing from other customers and staff. Small business owners are pretty anxious about being able to pay rent with declining business and sales. And worker engagements were largely focused on how to keep themselves safe, how and where to get tested, and dispelling myths around COVID and testing. Canvassers used this time to share additional worker resources such as the Office of Labor Standards Enforcement Advice Line and testing resources. Next slide, please. Our team did observe that many of the canvas businesses lacked a social distancing protocol as required by the health order. There was also a lack of social distancing markers. In these situations, our team informed the business of these requirements and assisted with measuring and marking the floors to facilitate social distancing. I want to add that we adhere to an education first approach in lieu of enforcement. So businesses are not reported by the Chibet team for lack of a social distancing protocol or social distancing markers. Most often the issue is resolved on the spot. And other times our team does make a return visit to make sure that compliance is in place. Next slide, please. Here is a dashboard reflecting our cumulative outreach metrics as of August 28th. Our community health workers have experienced mostly positive engagement and have even noted a warm reception. Previous slide. Right here. Thank you.
Sorry.
Thank you, Dr. Smith. Here's a dashboard reflecting our cumulative outreach metrics. Our community health workers have experienced mostly positive engagements and have even noted a warm reception during the daily debriefs. Engagements with small business owners and workers have gone as long as an hour, and some have resulted in requests for demonstration presentations for larger groups of small business owners and workers. Engagements have been conducted in English, Spanish, Vietnamese, and Chinese. Next slide, please. Here's a slide with some photos of our team. They convene at the beginning of each shift at an outdoor setting and debrief each night via Zoom. Our wonderful Chibet workers are also doing double duty as census ambassadors, making sure to share census-related information during their engagements. Next slide, please. This concludes the business engagement portion of this presentation. I will now turn to Dr. Ana Luisa Garcia to provide a status update on residential and community engagement.
Thank you very much. Good afternoon. The three coordinating agencies for the community health engagement strategy have been very busy planning, recruiting, hiring, and training their collective base of 36 to date community health workers, patient navigators, promotores, and community navigators, which will all go live the week of September 8th. I do want to share a few highlights that are currently underway. The African American Community Service Agency has hired community navigators, and Unity Care launched COVID-19black.org, an initiative that is really centered on highlighting content, stories, COVID-related information, FAQs to dispel myths for the African ancestry community. They are also in the process of collecting additional stories to highlight the impact of COVID on the African ancestry community. The Si Se Puede Collective, which includes Somos Mayfair School of Arts and Culture, Amigos de Guadalupe, Grill Family Services, Meta, and Vegelution, just launched a 3-day Spanish-focused COVID training for 32 promotores, and they are in the process of co-designing the phased approach for community outreach, will include social media, phone banking, and on-the-ground strategies to reach a larger number of families and individuals. Also, as part of their outreach strategy on testing, the collective is promoting COVID testing available in the East Side with a focus on the School of Arts and Culture. In addition, the Community Health Partnership has hired their health educator, has completed training for their community health workers, whom have actually hit the ground running and are actively working on outreach and navigation activities. The Community Health Partnership has also established an agreement with Care Messaging to begin large text message outreach efforts to community health center patients in targeted Santa Clara County zip codes. Next slide, please. In addition to Chibet, the community health worker model, the work with promotores, the EOC community engagement and racial equity team has been actively working to coordinate efforts underway in East San Jose. In parallel to launching the community health worker model, we have been working with the EOC, Public Health Department, and our community partners to build the infrastructure for an East San Jose hub at our public health offices on Story and King. Next slide, please. The idea behind a hub is to wrap our arms around all of the COVID-19 efforts with a focus on East San Jose families. This includes data collection, better understanding both quantitatively and qualitatively the impact of COVID on families, Latino families specifically. There's a focus on training and outreach and engagement. And also, as Dr. Redmond mentioned, community-based contact tracing and testing. We are going to be pilot testing a number of strategies. The plan is to have the community engagement team housed at the public health offices 2 days a week, Monday and Wednesday, and for us to have proximity and connection to community and to really be connected to the work that in a way that we definitely can't do from the EOC. So we're really excited about this opportunity to really extend the reach and the impact of our community engagement strategy in partnership with the promotores and in partnership with residents of the East Side. The ideas for phase 2 moving forward is that as we are doing our data collection and better understanding the scale and the scope of the issue and the needs of this particular community on how to support families, that we will expand services and strategies based on data collected over the next month. That concludes the presentation.
I think we'll give it back to Sarah so you can ask questions. Hold on just 1 second.
Thank you. I'm going to go to public comment on COVID-19, and then I'll go to the board, and we'll use our customary 15-minute intervals to get us started. So if I could ask the clerk to please call on the public speakers, and then we'll go to the full board.
Next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You will have 1 minute to speak. The timer will start when you begin speaking.
Thank you, everybody. Scott Largent. I was able to get a call back after the Health and Hospitals meeting, which was a great thing. So somebody was actually paying attention. They provided that phone call, and we figured out why I didn't get the results for my COVID test. Been out of the mix for a long time, kind of getting back into the swing of things in life. And my handwriting is kind of chicken scratch. I'm used to typing, just been out of the mix. So when they entered in my email address, it was incorrect. Same with some of the other information. I did provide an ID. I don't know why this stuff isn't just auto-filled and already in the database, so we don't have to worry about something like this happening. This is more likely going to be the way for most of the homeless community that's been out there. They haven't been writing for a long time. They haven't been typing. They've been in a whole different world. So I do appreciate that somebody's paying attention to that. It did take 3 weeks to get the results, but I still got it. So thank you.
Our next speaker is John Alpert. I am unmuting you. Please accept the unmute. You will have 1 minute to speak. The timer will start when you begin speaking.
Will the county permit indoor swim schools to open in Tier 2? The state site does not list indoor pools in the drop-down menu, and the CDPH Department of Essential Services has previously deemed drowning prevention swim lessons as essential. As you know, drownings are on the rise. The initial hospital costs associated with a drowning victim with brain injury is $5 million and takes dozens of hospital staff to be involved with a victim's care. Water safety, including swimming, is an important lifelong public health approach to preventing drowning. I noticed Tier 2 allows for indoor restaurants to open where people need to remove their face masks to eat. It also lists aquariums and many other non-essential places to open, but does not address indoor swim lessons. Indoor pools are safe with the proper safety protocols in place. We have had 0 confirmed cases of COVID amongst our students and teachers when we were open in June and July. We teach thousands of Santa Clara children how to swim. Due to the closure by the county, all life-saving lessons have stopped. This is a public health need, and we should be considered essential as we are providing a life-saving skill. Thank you.
Our next speaker is Almaden Valley Athletic Club. I'm unmuting you. Please accept the unmute. You will have 1 minute to speak. The timer will start when you begin speaking.
We can't hear you if you think you're unmuted.
Almaden Valley Athletic Club, are you there? I'm getting no response. That is our last speaker.
Thank you. What I'm going to do, I'm going to go to the to the board and start with Supervisor Cortese.
Thank you, President Chavez. I just have one overarching question, and it has to do with the contact tracing. Great job, overall. Dr. Rudman, this is, probably the second or third great briefing I've had in the last couple of weeks from you in terms of what's going on. Obviously, the linguistic issues, the language issues are still a serious work in progress. So just as a general comment, probably stating the obvious, that's clearly something that we should be able to accomplish. And I hope you'll let the board know if there's anything more that's needed in that regard, just to get that evened out. But my overarching question, and I don't know if Dr. Cody should be responding, in terms of how broad this question really is. When Dr. Cody was presenting on the various sectors and where the frequency, if you will, of positives were coming from by sector, it made me remember that when we were sort of working on all of that, as a county a couple of months ago, and we were talking about the protocols by sector and how important it was to set them up so that it would be efficient and effective to come in and contact trace in those sectors, meaning that they would keep data, they would keep information. Obviously, there would be sort of a closed gate system, especially in areas like construction or areas where you don't normally have intake. And so obviously we're tracking all that. And then when I go over to, that's on the information Dr. Cody gave us. And then when I go over to Dr. Rudman's side of it, I see that all this communication is happening, or attempted communication. My overarching question is, to what do we know about, the real outcome that we were shooting for in the first place when we decided that all that work was important? It seemed to me the outcome was to disrupt the virus. So what I'm saying is, and don't take this as no good deed goes unpunished, but I'm really impressed by statistically all this progress we've made and sort of the volume of work that's being done and the number of contact tracers we have, for example. But I don't really hear, as we went through the slides, and therefore we are now, intercepting the virus, quarantining people, and disrupting the virus like we planned to do months ago. And that is resulting in a healthier, safer Santa Clara County. I feel like I want to say that's probably happening, but I don't see it presented that way. And and how can we get to that very fundamental question? How does this achieve our temporary pre-vaccine goal of disrupting the virus? How does it today, or do we know that it's even working?
Hi, Supervisor Cortese. This is Dr. Cody. I'll see if I can best answer your question. I guess step back for context. We, of course, have many different interventions that we're all doing simultaneously, ranging from masking across the population to social distancing protocols to case and contact investigation, to increased testing and case finding, et cetera, et cetera. And to be honest, it's quite difficult to assign each intervention and what proportion of transmission it might be preventing. I also want to say that the case and contact investigation that we're doing at scale is something that we've never done before, and no one has ever done before. And it's iterative, and we're learning. And so we are both trying to measure how much transmission we might be preventing, but at the same time, we're also learning that there are some benefits that we didn't even think about that are occurring. And I think Dr. Rudman highlighted some of those, which is catching people who are ill, catching them earlier, ensuring they get into care faster, and that may be preventing some bad outcomes that we wouldn't have prevented if we didn't have it in place. So I'm not sure that's a very clean answer, but it's an honest answer. That's, I don't know, if Dr. Rudman is nodding. Thanks for the question.
Thank you. And I'm just, I totally understand the answer and how it's hard to attribute cause and effect here when we're, throwing so many things at it and apparently doing a pretty effective job relative to other counties and what we've seen elsewhere in other states. Our positive rate for testing is much lower than the state average, and it has been. And I just want to say I ask questions like that because those broad questions seem to me what we hear from the public or what we're trying to respond to in terms of keeping the public on our side, keeping the public committed and focused to cooperating and doing the things that need to be done. I'm certainly heartened by the testing numbers and the progress at the Fairgrounds site. I think that's almost astounding that at this point, after this much fatigue, we're still getting 1,000 people at a time lining up for tests. I think that's all really important. But these big questions like, okay, we're investing in this and contact tracing is going on, but is it going to, deliver us to the promised land, so to speak, of, getting off of anything that even resembles a watch list or getting our economy open back up? There's some nexus there in people's minds. How effective is this work and this investment? So I appreciate you continuing to try to answer that question. I'm satisfied with the answer today, but I might ask it again in the future. The other question that comes up often from constituents, and I've tried to answer it in my own amateur way, but maybe you can answer better for us, is, what can we say about the recovery rate from this disease? I have a close friend right now who contracted COVID-19 and went from being the most robust person in the world 2 weeks ago, trying to organize charities for other people, and to suddenly being in what he described is a very hellish situation trying to recover. And this is a very robust individual, a middle-aged person in great health. Those that we know, we can monitor anecdotally, our friends, we can see if people are recovering or not. But we get the big question from our constituents, okay, 23 people died between last Saturday and the Saturday before in this county, but how many people are recovering? And I think it's both a wish for some positive news as well as just a better understanding of the risk. What is that metric? Is that everybody that we know of that has contracted it minus the mortality rate equals the recovery rate? Is it that simple, or is it just an unanswerable question?
Well, you're asking a really, really good question and highlighting something that's really important, which is that it's incredibly variable and not always predictable how people are going to do with a COVID infection. And even people who are otherwise young and healthy may do badly and have problems that persist for a long time. And it's difficult to predict. We do not measure, have a way to measure recovery, as in you're restored to the, your health prior to infection because we don't follow people for long enough. What we can say is how many new infections, how many hospitalizations, and how many deaths. So it's not as nuanced and granular as you might like. But I think your comments highlight something really important, which is that outcomes can be highly variable and not always predictable.
All right, I'll settle for that again for this week, and I appreciate that it's also indeed probably the best answer that you can give me. I'm not sure that it would be inappropriate, and maybe it's worth thinking about, to put on the dashboard just the basic math that you just described at the end there. You know, to date, this many folks have contracted in this county. To date, this many folks are still in ICU, and to date, or hospitalized in general. And to date, you know, this is the mortality that we know of, with a big asterisk at the end that says this doesn't include all cases, because all cases haven't been tested or determined, or whatever the public health language is for that. But I don't know. I don't know how my colleagues feel about that, or if that would feel like misinformation, but it seems like just putting the math out there, as simple as it is, that we do know and we do understand, would be helpful for us on the public interface side to be able to point people to and say, that's what you want to know? Well, here's the best math we can give you at this time. Anyway, thank you for that. That's a suggestion, in other words. Thank you for that, President Chavez. That's all for me.
Thank you. And I'll go to Supervisor Ellenberg.
Thank you so much. I want to thank all of the staff for this really detailed and informative report this week. Thank you. And I'm particularly excited to see some direct community engagement and activism of our CBO partners with deep relationships in the community who are doing this work. So thank you for moving ahead with that. I'm going to go back for a moment to the state and local health orders with some questions for James Williams. James, you mentioned some alignment considerations between the new state guidelines and our local order. Can you provide any more detail on the adjustments that we may be considering in the sectors or businesses that are under review?
Yeah, I'm just referring to specifics in the actual guidance regarding operations, not sectors that would be changing from the risk reduction order. So sorry if that was misleading, but you know, the state puts out very detailed guidance and directives. For example, how to operate your hair salon, for example, indoors, and you know, a lengthy document related to that, for instance. And they've done so in every sector. We have similar guidance or directives, rather, in some of those sectors. And when the state changes theirs, you know, we continue to try to, wherever possible, have alignment so that people aren't being, you know, so that there's as little friction as possible in terms of how to actually run an operation in a safe manner. Of course, there are instances where we do have some more specific requirements that our health officer believes make sense in the context of that specific industry. But that's what I was referring to.
Thank you for clarifying, and to take that just a little bit further on the importance of alignment and consistency. Are there any coordinated discussions occurring right now amongst the Bay Area health officers relative to the new state framework and how to maintain consistency in the region as counties may move into different tiers at different times?
Nothing that I'm aware of at this time.
Dr. Cody, do you have any, is there anything, are there conversations happening right now?
This is Dr. Cody. There's nothing, nothing really to report at this point.
Okay. Just something to think about that we could again run into a situation where we found ourselves in the spring if we're in the purple tier, San Mateo's in the red. I'm not remembering the other colors. But clearly there will still be movement from county to county. James, I'd also like to hear your thoughts about the future of businesses that are currently operating outdoors as we move toward the fall. Whether there will be revisions of the risk reduction order, might that be considered to reframe some of the indoor and outdoor operational issues? And what happens if, hopefully this isn't the case, but if we're still purple when cooler weather comes?
Yeah, I think that's something that is just not able to be known right now, because the restrictions that are in place are really based on the risks associated with COVID transmission at this time. And, you know, there's a lot of unknowns going into the fall, not only related to what may be happening with transmission across the state and nationally and internationally for that matter, but how it may interact with flu season.
Right.
That's been something that's been of significant concern, certainly. And, you know, even in a normal flu season, that puts significant strain on our hospital system here locally and across the country. So, you know, that, and you're absolutely right. Obviously, the weather changes. So, you know, we'll have to see how those things evolve. We have gotten no indication from the state those questions either. Fortunately, we're in an area that has much better weather than many parts of the United States, and hopefully that'll let us maintain as many activities outdoors as possible for as long as possible, given everything that we know to date about how much safer outdoor activities are relative to indoor ones.
Right. Thanks for that response too. And I hear you on the beginning of flu season. Of course, we don't historically close down for flu season, so I think there's still hopefully some room to keep pondering that, looking at our numbers and thinking about what our options may be when the weather does get cooler. I want to switch to a couple of questions about the school reopenings, and thank you. I think Dr. Rudman, this is your area, so thank you very much for adding the list of applicants for waivers and approvals to the website and for the additional information provided today. I'm still interested to know, how do we assure the timely review of applications? And as part of that answer, how many staff do we have assigned as liaisons or part of this review team? And are we currently meeting the 14-day response time that the applicants have been told to expect?
Hi, Supervisor Ellenberg. This is Dr. Cody. I am speaking on behalf of the schools team today. We've rejiggered our processes a bit so that we can process waiver applications more quickly. And actually, just over the last few days, we've been able to work through quite a bit of a backlog. We don't anticipate that we need to staff any differently in order to address the backlog and process them. And we do our best to go as quickly as possible, but not all of them make it from time of submission to completion, although we certainly try to get some response back to the applicant within 14 days, not always able to accomplish it.
So then, Dr. Cody, if we're not able to get them all in 14 days, why do you think that we wouldn't benefit from more staffing in that area? Well, I don't know how many people there are doing it, first of all, but you suggested that you don't need any more.
Right. A lot of the issue with timing has to do with the complexity of a certain application. For example, the application may come in not at all complete, and so there may be some back and forth to get the application complete, and then some discussions with various teams to ensure that the school opening would be as safe as possible. And sometimes that back and forth takes a while.
Got it. So it's not necessary. It's not a question of applications just not being addressed or begun within that period of time.
Correct.
Great. Thank you. That's helpful. What exactly is the requirement for the California Department of Public Health review of the waiver applications, and how long does that step usually take?
So the time between when we forward an application to CDPH for their review and approval and when we get it back is usually rather short. I don't have exact numbers, but it's, usually certainly within a week.
And that's included within our predicted, or our average 14-day turnaround? It includes that week?
No, I don't think so. Usually it takes time for, so a school would submit a waiver application. The ones that move quickly are ones that are very narrow in scope, or that are exceedingly complete and thought through when we receive them. So that takes less on our end.
Mm-hmm.
But the 14 days is really about the back and forth on our end, not inclusive of the time it takes for CDPH to review and approve.
Got it. So that adds potentially an additional week.
That would add some extra time. That's correct.
Okay. And applicants are aware of this?
I believe so. I mean, needless to say, what we strive to do is to have good communication with applicants so they know where they are in the process and what the issues are, and so that there's good technical assistance to support the application.
Good. I think it would be very helpful to make clear that the 14 days is just our piece and that there is an additional state piece that that could take up to another week, because I do think that there is some confusion about why it often actually takes longer than the projected 14 days. I'd also asked about the weekly calls happening in the EOC with school superintendents and trustees on reopening issues. And I'm concerned from the slides that private school administrators don't have the same level of access to address questions at a school leadership level. Is there any reason that the calls for superintendents couldn't be expanded to include private and charter school leadership?
I think
to the
there's
extent that they
different
find it? I apologize. Go ahead.
Yeah. Well, we'll certainly take that back. I think there's different types of issues that come up with the public school districts in contrast to the private and charter school districts. So, different kind of need that would need to be met. We can discuss with our education colleagues.
Okay, and I won't look to create a problem where one doesn't exist. If I am hearing in a couple of instances that folks representing those institutions would like to have more access, but if you're finding that it's too different, and maybe if the number is small enough, we can handle that outside of this meeting with a couple of particular cases. Thank you. I really am looking forward to more information on the status of reopening plans at the special hearing next week. I want to just wrap up with a couple of questions about contact tracing and isolation supports. I really am, again, glad to see the partnerships with CBOs on tracing efforts moving forward. Thank you. After these months since my referral in May, I'm hopeful that this partnership can help address the gap in language skills and build community trust in the tracing effort. Have contracts with these partners been executed yet? And what is the source of funds that will be supporting this work?
Thank you, Supervisor. This is Dr. Redmond. The piece I presented on specifically is a portion of previously contracted funds with a different entity that will allow assignment of county resources into the CBO's in-kind support in the form of contact tracers that we will onboard ourselves. There are additional contracts with the CBOs themselves specifically that are not operated specifically out of my group, but by the Community Health and Business Engagement Group. And Lily Garcia can speak to that in further detail if you'd like. On our end, we are still, those contracts are not yet final. We are still working out the final details of the agreement.
Okay, and certainly with everything else these days, we're looking for as much efficiency as possible. And it sounds to me, if I heard that correctly, that this is a shift in dollars as opposed to new dollars. Did I hear that correctly? That's
right. These are positions that were already slated to be utilized as joining our existing contact tracing workforce, doing the work we were doing in sort of that remote-based fashion, but understanding that it needed to be done in a more community-driven and informed fashion. We're shifting the use of those existing dollars in that way.
Right,
So
I'm really glad.
Yeah, Dr. Redmond, just for clarity, is this the Haluna contract?
Yes, these are positions through the Haluna contract.
And then the other is through the 1.5 that came through the referral from Dave and I think, Susan, for the other activities.
Mm-hmm.
I'll pass the phone to Ana Lilia to answer the second piece, please.
Hi, this is Ana Lilia. The 50 positions through Haluna, there is an opportunity to house contact tracers within community clinics. And this is these are dollars that are supported through Haluna. The community health engagement model, Chabet, those are separate dollars to support community engagement efforts. So they are two separate funds.
Yeah, and that came through we already voted on that money a while ago. Susan.
Yeah.
Yeah.
Yes, that's correct.
Wanted to refresh on where it was all coming from. Just finally, my staff was informed that public data on the tracing team metrics will be posted online today. Thank you. And as the tracing team continues to build out and improve the program, and particularly as we engage city partners in providing isolation supports, I'd like to see this resource include data on the cases and contacts that are referred for supports and data on how many actually receive those supports and how quickly the link is made.
Wonderful. Thank you, Supervisor.
Thank you so much. Thank you all again for all of this information. It is really informative and helpful.
Thank you, Susan. Joe?
Thank you, Madam Chair. And first, a question for the testing team. And as I tee up the question, I should just say thank you for the effort to ramp up the testing over the past few months. Colleagues will recall I was pushing to try and ramp up the testing. And I think real progress has been made. And I wanted to acknowledge that and express my appreciation for it. I think it's essential both on the health side and the economic side as well. And in fact, I have a copy of the San Francisco Chronicle today with the editorial headline that says, "Reopening still depends on testing." And, here we are 6 months later. So I appreciate what the county has been able to stand up in the way of testing opportunities. Want to continue to urge folks in the large healthcare operations around the county to step up the effort as well. I think there is still significant room for improvement there. Let me go to the testing team, though, with the question, Madam President, which is, within the last week, I believe, we heard from the FDA approval for a new antigen test, which is reported to be both appreciably less expensive and with a very quick turnaround time, although as I understand it, somewhat less precise. I wonder if the testing team has had time, I know it's only been within the last week, to give any thought to what that might mean both in the near term and over the longer term in terms of our test, the ability to keep people healthy and to get.
Joe, you're cutting out a bit. Just the last couple sentences.
Thank you.
Dr. Cody, did you get all that?
Hi, this is Dr. Fensterscheib. So thank you for that question, Dr. Samidi. It sounds like, I feel like he knows a lot more than I do in many instances. Supervisor Samidi, we actually have been looking at that and other antigen tests. And for those listening, I just remind people that most of the testing that we're doing now is PCR testing, and that's done, again, with the nasal swabs for the most part. We're looking for genetic material called RNA, which is like human DNA. And for the most part, those have to go to a lab, or sometimes they have a machine at a point of care site. Those tests, as we know, have taken a while to turn around, and they also are more expensive. The antigen test is different. it's not looking at the genetic material. It's actually looking for live virus, which is called the antigen. And those tests, again, are just now being developed. There are a lot of them out there, a lot of startups. But the one you were referring to is made by Abbott, and it's called Abbott Binax Now. And it looks very, very promising. The cost will be much less, perhaps $5 a test. The turnaround time is 15 minutes. It's the way it's done is you would do a nasal swab, insert it into a small card, like a credit card, add a little solution, and then within a short amount of time, 15 minutes, there would be a color band, a color reaction. So we're very excited about that. That's something that could be done by anyone, by teachers before they go to school, students, frontline workers. I think this is hopefully down the road going to be a dramatic change in the way we are dealing with COVID. However, here's the caveat. The U.S. government bought all of these tests, and they've spent $750 million purchasing 150 million tests that Abbott will be able to produce between probably now and 2021. We've reached out to Abbott, and that's basically, we're on a waiting list for information, but we have no access to that test. The other thing at this point is the test is also only approved for people who are symptomatic, meaning you have to be within 7 days of symptoms. I'm encouraged that there will be down the road a change in that, and it will be approved for asymptomatics, but right now it's just for symptomatics. But however, we have no access to that particular test, and most of these other ones also we have no access to at the moment. But I think this is the wave of the future, and time will tell.
Do we know what the federal government plans to do with the 150 million tests that it has preempted?
They haven't told us. I don't know. I'm assuming they're going to look at utilizing them in high-risk situations, such as nursing facilities. But perhaps they're looking at. I don't know. I don't want to guess.
All right.
We haven't been told. We haven't been.
Thank you. I would appreciate it through the chair, Dr. Fenstersteib and other members of the team, if there are developments along these lines and or related to the distribution of such tests and or the availability of such tests to the broader public, if you would just keep us posted from time to time with these reports. So if you could add that to the list of many things that we ask you about on a regular basis, I would appreciate hearing about that as developments warrant. The second is a very specific question that comes up a lot in my office with constituents on the sort of individual household basis, as distinct or distinguished from the business environment. And it may be that Mr. Williams is the best one to start with this, which is, Mr. Williams, it's my understanding, please correct me if I'm wrong, it's my understanding that under the old structure that was in place, the combination of state order and county order meant that, notwithstanding the fact that it was happening a lot, people were, as a matter of public health orders, prohibited from driving down the street and having one couple join another couple in their backyard to socialize, because that was a gathering. Do I have that recollection correct?
Yes.
And so now we have a new system with color codes, and we're in the purple color code. And what's the current status then of that kind of behavior? Is it lawful? Is it unlawful? Because, you know, for all the complexities and all the business intricacies that we are trying to address, for a lot of folks, they just want to know, can they walk down the street and go visit a couple of neighbors? So what's the answer to that as things stand today?
So there's no change in the state's rules regarding gatherings in the purple tier. The only changes are the hair salons and malls at 25% of capacity. There's also no change in the county's local order, and under the county's order, we actually have specific directives related to gatherings, and those are, just to remind folks, that indoor gatherings are prohibited, outdoor gatherings are allowed up to 60 persons following the appropriate rules under the directive. The state has, let's just say, not always been a model of clarity on the issue of gatherings, but continues to not have any provision allowing general social gatherings.
Of any size?
Correct.
So the gathering that I described of two couples who live on the same block, which would of course be 4 people, is a gathering, yes?
Yes.
And therefore prohibited, as you understand it, yes?
Yes.
Okay, let's just make it a little more precise. And if Sally lives on the same block and walks down the street to sit in the backyard, socially distanced with Sue, does 2 people make a gathering in your understanding?
Under the state rules, that's my best understanding, yes.
All right, thank you. And then a pivot to a business issue. We lot in the newspaper about barbershops, salons, nails, estheticians, which used to sort of come in the same sentence or paragraph with a conversation about gyms. That does not appear to be the case in this instance. Can you clarify on that for us all, please?
So the state has broken those up into different categories. So in the purple tier, hair salons are allowed, but none of the other items. In the red tier, personal services, which would include nails and massage and other personal services, would be allowed indoors. And gyms at 10% of capacity in the red tier. So the state has put those into separate buckets, so to speak, with separate capacity criteria for those different categories.
So as things now stand, since we are in the purple tier here in Santa Clara County, the gym is closed unless it's outdoor activity. Is that correct?
That is correct.
But if we were to work our way into red, then the gym would be open at 10% of capacity. Is that correct?
That is correct.
And if I were to say capacity is defined how, you would say what?
The state hasn't provided a definition of capacity. That being said, we believe the most reasonable definition to use at this time would be the fire marshal capacity. I just want to note regarding that question, the risk reduction order that the county has had in place now since early July has a density requirement, which is different than capacity, and is really based on, and when that was developed, we had looked into the question of using, for example, fire marshal related capacity, fire code capacity, and determined that instead a density standard would be something that could be applied more consistently because it's not based on, availability of egress, for instance, because our concern really was with the number of people in a space as opposed to how quickly people could exit a building in the event of a fire. And so that's why the risk reduction order uses a density limit. Those density rules remain in effect for anything that is operating. And in the event that the state's capacity limit would result in a higher number than the density, folks would need to continue to follow the density rule. And in the event that the state's capacity limit would result in a lower number than the density that folks would need to follow than the capacity rule. So it's whichever has the fewest number of people in the space. I think that may sound more complicated than it actually is, because it's really whatever number is lower.
Good evening. It seems like just yesterday that we were at our first convention, where my husband accepted the Republican nomination and then became our 45th President of the United States. Yet the energy and enthusiasm for who should lead this nation, it is real today as it was 4 years ago. I know I speak for my husband and the entire family when I say we have not forgotten the incredible people who were willing to take a chance on the businessmen who had never worked in politics. We know it was you who elected him to be Commander-in-Chief, and we know it is you who will carry us through again. We were humbled by the incredible support then, and we are still grateful today. I want to acknowledge the fact that since March, our lives have changed drastically. The invisible enemy, COVID-19, swept across our beautiful country and impacted all of us. My deepest sympathy goes out to everyone who has lost a loved one, and my prayers are with those who are ill or suffering. I know many people are anxious and some feel helpless. I want you to know you're not alone. My husband's administration will not stop fighting until there is an effective treatment or vaccine available to everyone. Donald will not rest until he has done all he can to take care of everyone impacted by this terrible pandemic. I want to extend my gratitude to all of the healthcare professionals, frontline workers, and teachers who stepped up in these difficult times. Despite the risk to yourselves and your own families, you put our country first, and my husband and I are grateful. I have been moved by the way Americans have come together in such an unfamiliar and often frightening situation. It is in times like this that we will look back and tell our grandchildren that through kindness and compassion, strength and determination, we were able to restore the promise of our future. Businesses stepped up and volunteers stepped in. People were eager to share ideas, resources, and support of all kinds with neighbors and strangers alike. It has been inspiring to see what the people of our great nation will do for one another, especially when we are at our most fragile. Speaking of strength and determination, we recently celebrated the 100-year anniversary of the passage of the 19th Amendment. Yesterday, on the North Lawn of the White House, we unveiled an exhibit dedicated to women's suffrage. The exhibit called on children from across the country to send art honoring the meaning of this important time in women's history. When I was judging the entries, I reflected on the impact of women's voices in our nation's story, and how proud I will be to cast my vote again for Donald this November. We must make sure that women are heard and that the American dream continues to thrive. Growing up as a young child in Slovenia, which was under communist rule at the time, I always heard about an amazing place called America, a land that stood for freedom and opportunity. As I grew older, it became my goal to move to the United States and follow my dream of working in the fashion industry. My parents worked very hard to ensure our family could not only live and prosper in America, but also contribute to a nation that allows for people to arrive with a dream and make it reality. I want to take the moment to thank my mother and father for all they have done for our family. It is because of you